Can you get some? Nothing. Zero. Okay. Where I'm on room. The lighting control works. It says the projector's busy. Yeah. Well, I don't know. I've been trying 19 different things to get this to work. We just, under projector control, we just hit that and it said, projector busy, wait. Maybe it's going to come on in 30 seconds. I have no idea. Uh-huh. Yeah. Is there anybody in the building? Because I got a big class, and I really... Okay, quick. All right, so I am... Let's see, let's just wait a second. I'm down to... It says projector busy. Let's see what happens. 4, 3, 2, 1. Last step. Okay. Please wait. Well, I've been doing this for years. I don't know what's going on today, but it keeps saying projector busy. Please, I need somebody here right away. Okay, do you have any other ideas? Yes, it says projector busy. Okay. All right. Thank you. Bye. She's no clue. It says the system needs to be restarted. What else did we try? We did room controls. But how?
It's a little risky.
Yeah, I think the guy's supposedly coming. I mean, the last guy.
I shut everything down. You can come after him every meeting.
No, it's a different guy. He couldn't even meet. He said, I shut it all down, I don't know. I was using the mic. Okay, so here we go. So, still nothing. I don't see anything on up there. Out of screen, slow and turn lower the screen.
It's like doing something. Yeah.
Well, let's just go through these. Could this have been possibly disconnected by this bozo? It's...
Well, I'm going to get my blank on the screen or something.
Nope.
Exactly. There should be like a big blue screen. Yeah, exactly. But now we don't have the like wait time. So I don't know. Aside from the reboot, I don't know what needs to be. That's the wrong projector.
That's outer screen.
Yeah. Center screen. I mean, yeah. So I think that this main projector is just off.
My grandpa's apartment is it did not look like it was so let down. Everything was here. It was so good. But No, ever since my grandpa passed away, it's been weird 5 days since he passed away. Nobody's lived there. It's like my grandpa lived there till technically I was his daughter when she raised me. So, I mean, it's nice to see what's in the area. It's a lot of experience that kind of burnt out.
Also, what is that? Genealogy stuff.
Yeah, I moved after I graduated. I moved there. I contemplated becoming a director and community college, like getting, doing my PhD locally in the U.S. Yeah, becoming an instructor. I'm 4 years. And then it'd just be like, when I go home, probably 12 hours. 12 hours. Exactly. All over. What dog is?
Okay, great. Am I on? Are we okay in the back? Over here? Okay? Good? All good? Okay. All right, great. So, a quick announcement. I switched the order of lectures, so next Monday we're going to do epilepsy, and I'll be sending out the slides. And the reason we're going to do epilepsy next Monday is because next Wednesday I have a visitor, a collaborator here who's the head of the epilepsy program at the Cleveland Clinic, which is one of the biggest programs basically in the world. And he's going to come here at the beginning of the class for 15 or 20 minutes and talk to you about all the perceptual distortions and auras that are associated with people who have epilepsy. And I think it'll be extremely fascinating presentation. His name is Patrick Chauvel, and I might even send out one of his papers from a while ago, just talking about the different perceptual disorders people can have as a prodrome to having a seizure. So before we get started on epilepsy, real quick housekeeping. Again, this is the, this is the distribution of the grade exam. Everybody should have gotten their scores back by now. You can see the mean is basically 84. We adjusted it to the standard, strong B, which we do all the time, and all of you lie somewhere in there. So I think this looks like pretty much the distribution for this exam for the last 10 or 15 years. So congratulations to everybody who did well on the exam. Okay, so today we're going to talk about a super important topic that will face every one of you at some point in your life, whether it's currently because of family members or actually because of you as you get older, and that's the problem of dementia. So as we've done in the other clinical parts of the course, let's just get a saliency read on how many people know somebody in their family or close to their family who has decreasing memory with aging or actually has frank dementia, okay? If you look around the room, it's about half the room, okay? So you can so this is a huge emerging
not even just emerging, already here public health problem, because it's pretty simple. Most degenerative disorders with aging, the various types of dementia that we're going to talk about, are related to age. The older you get, the more likely you are to get it. What's happened really simply is that the lifespan is increased for people in the United States because of better treatment of vascular problems, stroke, heart attacks, cancer, etc. People are living longer, which means they're more susceptible to getting these diseases, basically, of aging. So here's just the epidemiology. Let me get this a little bit. Where's the room control? I think this one's better. You see it a little bit better. Okay, so you can see the growth of the 65 age population from 1900. People didn't live that long, right? Infectious diseases, other miseries. And the bottom line is here we are here, and you can see a huge increase of people living much, much longer into their 80s. The average age for a woman now is 83 or 84. Average survival, many women live into their 90s or even to 100. The average age for men is around 79 or 80. And again, people can live for very long periods of time. Now you can see here the other slide here, which is the critical epidemiology slide. So that's, now if you notice, by 2050, the number of people who are over 65 is going to be a staggering increase. We're talking of millions and millions of people. So now we go right here to roughly here, 2020, and we can see the prevalence of Alzheimer's disease. It's not that common between 65 and 75, right? But it happens. There's 500,000 people. If you go into the next age bracket, you can see it's in the 3 to 4 million. And then if you go into the over 85 bracket, the actual incidence at autopsy of having the findings of Alzheimer's disease actually goes up into the multiple millions, 6, 7, 8 million. And here's the emerging health crisis. And you'll all be around here. This is 2050. Take a look at that. 12 million people, at least. That's a lot of people because there's a massive amount of costs, both taking care of the people and a lot of cost in terms of the misery that the person with the disease suffers and the family members, have to deal with from loss of the function of their loved one. So, whoops. Get back here. Oh. Again, one more slide of this to hammer it in. The prevalence of Alzheimer's disease, over 85, 40%. The prevalence at age 75, 15%. And actually, as you'll see a little later in the discussion today, even normal people at age 70, if you put them in a PET scan and they're 100% normal cognitively, about 10 to 15% show amyloid deposition already. Right? So you get amyloid deposition long before you're symptomatic. And you can see this amazing statistics, the number of women living over 100 years in Sweden and Japan. Massive, massive increase. And it's only going to get more dramatic with time. So what is Alzheimer's disease? In general, what is dementia? Alzheimer's in particular. This is an Irish author and poet. I think she really describes it, unfortunately, extremely accurately. Alzheimer's is, in fact, like an insidious fog, barely noticeable until everything around has disappeared. After that, it is no longer possible to believe that a world outside the fog exists. You have a progressive loss of your ability to think, plan, organize, and remember. And that's the key. Remember, dementia is not an abrupt thing. You get hit by a car, you get a massive brain injury, and you have cognitive changes. Those are stable. Alzheimer's disease is an insidious decline over time. That's an extremely important point to remember. You can see here an artist drawing himself as he progresses through the ravages of Alzheimer's disease. His normal portrait when he's young, and as he gets older, and he started having symptoms around here, and you can see by 2000 he can barely produce an image of himself. This is because he's just lost his ability to even know who he is or represent who he is. So, dementia, progressive loss of cognitive function. The patient is awake and alert. And they're not delirious like they came in because their sodium is abnormal and they're just completely out of it and they can talk to you. The cognitive loss eventually interferes with the most important thing, which is activities of daily living. Progressive global brain disease. Now, as you'll see as we talk about the various forms, different dementing disorders start in different parts of the brain. They have a predisposition for different areas of the brain. Alzheimer's is, depending on who you talk to, 50 to 80% of all demented patients have Alzheimer's disease. There's a characteristic clinical course we'll go into, and the pathology, which we'll go into in some detail, is a deposition of the brain of amyloid plaques, which are these sheets of protein deposited in the interstitial space between cells, and neurofibrillary tangles, which really are a fancy name for deteriorating and dying brain cells. Neurofibrillary tangles. Now, just one thing about dementia and socioeconomic status and public health for those of you interested in those topics. If you go to Alta Bates, it is true that 80% of the cases with dementia are probably Alzheimer's. But if you go to Highland Hospital, 7 miles from here, where there's the population is an underserved population with poor medical access and poorly controlled diabetes and hypertension, as we discussed as risk factors for stroke, their number one cause of dementia is not Alzheimer's. It's progressive accumulation of small strokes knocking out brain function. So even 7 miles apart, you can see large differences in the etiology or causes. The key pathological process is neuritic. These so-called neuritic plaques, senile plaques, amyloid plaques, it's all the same thing. They're deposition of amyloid, A-beta amyloid. Neurofibrillary tangles, the high amount of tau protein in the microtubular associated protein. It's inside these dying, twisted neurons. There's also degeneration of an area of the brain called the basal forebrain. It's a deep area. If you took a coordinate system between my fingers here and my fingers here, that intersection would be about in the brain where this basal nucleus is. And this is very important because this basal nucleus provides acetylcholine to your entire cortex. And the acetylcholine is very important for cortical function. It's also very important for memory, encoding, etc. So there's various pathologies associated with this. The clinical features, insidious. At first, you don't even know it's happened. It's gradually progressive. Oftentimes, the family member complains that the person who's affected has problems. So there's often an initial lack of insight into the fact that you're developing dementia. It most typically, because of the predilection for pathology starting near the memory areas of the brain and the temporal lobe and hippocampus, it most typically presents with progressive memory loss. And this is new learning, right? It's not old learning. Patient knows where they were born. They know where they went to high school. They know where they did this. They know where they went to college, but they may not remember what they did that morning. They can't lay down new information. As the disease progresses, you'll eventually also lose access to old memories. But at onset, it's a disorder of new learning, ability to take new information in. As the disease spreads across the cortex from the back to the front of the brain, you will get involvement in other cognitive abilities. Some people have language disturbances, aphasia. Some people have motor control problems, apraxia. Some have problems in visual perception. The behavioral, and often there's associated behavioral disturbances as the disease gets into the final stages of depression, apathy, and agitation. Has anybody seen a family member at the end stages? Do they have any of these symptoms? Right? Can you tell me what they had? Just to let the class know you've seen it. What did the family member? What was the progression?
She would get really agitated about things and it'd be hard for her to communicate what was upsetting her. And then, sometimes in some of these agitated bouts, she'd wander off and get lost, in the neighborhood.
Yeah, I'm glad you brought up that point because one of my postdocs in my lab is actually, as we speak, in Hong Kong, getting a GPS wristwatch for her 91-year-old grandfather who keeps wandering and getting lost. And his 90-year-old wife can't keep track of him, basically. She's cognitively intact, he's losing it, and she's actually putting him on there's a GPS device you can get to try to track people when they wander off. Do you know how the person started? Did they start with memory problems, or you just saw it at the end?
Just that.
Yeah. It's often hidden from people in the family, Anyway, all right. So you can see a typical, very, very typical clinical course in this disease. The causes of dementia, I don't want to say many, but there are a few. Alzheimer's is number one. And then in the last 15 or 20 years, we recognized another form of dementia that had gone through different names over the years called frontal temporal dementia. That dementia actually starts in the front of the brain and then ends up getting the back of the brain. So where Alzheimer's starts here with memory problems and ends up with problems with thinking and executive control, frontal temporal dementia starts in the front of the brain. So you're having problems with social regulation, executive control, thinking, etc., which we'll get into much more later in the course. I've discussed multi-infarct dementia, multiple small strokes, lacunar strokes, often related to hypertension and diabetes, picking off this piece of brain, and pretty soon you've got enough of your wiring disrupted that you're not thinking properly. And then, of course, there are reversible causes, which we'll talk about briefly. They're not technically dementia. Really, there's usually some medical problem that if you recognize it, you can treat the person and reverse their progressive cognitive decline. There's certain vitamin deficiencies and thyroid deficiencies, and there's standard tests that every patient gets to make sure we're not missing something that is treatable. So let me show you, a moderately impaired Alzheimer's patient. She's still very friendly. She's completely confused. She has a severe memory problem, and she's being examined by my friend and colleague Bill Jagus, who actually runs the dementia program at Berkeley and at Lawrence Berkeley Lab. So let's just take a look at him. You're going to watch that Bill's really very gentle with the patient, but he's very clear in extracting what her problems are, as you'll see.
Thank you for coming in, and we're just going to talk, and I want to ask you a few questions just to see how your thinking is and all of that, all right?
Yes, it's all right.
Okay, good. Okay, great. So, why did you come here today? Do you recall?
I came here for two reasons, and I don't recall what they were.
Okay, that's all right.
Severe memory problem.
Embarrassing.
Okay, it's no big deal.
Losing my
Is your memory? How is your memory?
Well, up until right now, I thought it was pretty good, but I'm beginning to wonder.
Let's see.
No insight.
To check your memory here. Do you know the date today?
No.
Do you know what month we're in?
Remember orientation, person, place,
How
time?
about the year? Do you know the year? I'll tell.
See, if you asked me the year I was born, I could tell you.
Okay, I'm going to ask you that in a minute. Let me tell you. It's today's October 23rd, 2001. Okay.
Yeah,
2001. Okay, will you remember that?
I'll try.
Okay, good. And we're at UC Davis Medical Center. All right. Let me give you some words to try to memorize. Okay.
Remember the mental
Words are
status?
Cat, apple,
Apple,
and table.
table.
Say those words again.
Cat, apple, and table.
Good. Now, in a couple of minutes, I'm going to see if you can remember those words.
Oh.
All right?
Yes.
Okay, good. Great. Do you remember the month now?
No,
Okay.
because I don't know what month it is anymore.
Okay. All right. It's October.
Never got encoded.
Yeah.
Okay.
Yeah.
Doesn't have a hippocampal function.
Can you spell the word world?
World,
Yeah.
W-O-R-L-D,
Right. How about spelling it backwards?
D-L-R-O-W.
Wow, that's great.
She's paying attention to him. She's trying, right, to cooperate.
Where did you
She's
grow up?
isolating her deficit.
Honolulu.
Uh-huh. Okay.
She's
How
very
old were you
relaxed.
when you moved to the United States?
How old was I when?
When you moved here to the U.S.?
Well, I moved back and forth many times between Honolulu and San Francisco.
I see.
Because I lived with my grandparents in Hawaii, in the islands, and my parents lived in Woodland, California.
I see.
I went to
Remote
school in the
memory
islands,
is
and
okay.
I'd come up in the summertime
New
in
memory
Woodland
is
and
shot.
die of the heat.
She's just showing all the features. Wait 5 minutes. Let's see if she remembered the words.
Do you remember those words I gave you a few minutes ago?
No,
Do you remember that I gave you some words? Can you remember that I did that?
no.
One of them was an animal. Was it a dog, a bear, cat, a lion? Any of those sound familiar? Oh, that's okay. How about this? Do you know what month it is now?
Oh, gosh. This is very embarrassing to me to not to know these answers.
Okay, that's okay. Don't be embarrassed. Do you know the year? Do you remember the year?
Okay, so you can see she remembers old things. All those things she's saying about Hawaii, they're all correct. So her remote memories are there. She can still access them. She can't lay down new memories. She has a very severe anterograde memory loss. She doesn't remember anything. Her free recall is 0. So that's, very profound problem with new learning. As you can see here, quite dramatically, here's your normal brain on a lateral view. And you notice how the sulci, the gyri, are packed tightly together. This is a global cortical atrophy. And what you can see is that the gyri are smaller and the sulci are bigger. That just means you're losing brain activity. You're basically progressively atrophying your brain. So here's a sagittal cut, and you can see the severe atrophy. And here's a coronal cut, again, with marked atrophy and large ventricles, a very terminal condition at this point. So the pathology, again, the key pathology that I'd like you to keep in your mind's eye is neurofibrillary tangles, which are composed of tau protein. There's a tangle right there, and this classic amyloid plaque. And a lot of the research has been targeted at removing this beta amyloid from the brain. I will just tell you it has not been successful, and there's even some question in the experts as to whether the amyloid is starting the disease or it's really an epiphenomena of the disease. And there's a lot of controversy and work in the Alzheimer world, which this class doesn't really have time to get into. Now, the distribution, you say, why did that lady have problems remembering with Alzheimer's? The reason is pretty simple. If you look at where the plaques and tangles tend to occur, the highest distribution is actually in these hippocampal medial temporal areas, which are the areas you need to remember anything. I tell you to remember something, and if you don't have that area of the brain, you're not going to remember it. It's really pretty much as simple as that. And you can see the plaque burden also in the lateral and medial temporal lobes. So these are the reasons, and these is, kind of at the onset. This is about probably where this lady is. As the disease gets more progressive and takes out the rest of the brain, she wouldn't be able to do the other interactions that she was having with Dr. Jagus during that movie. Some of the early work we did before we had tracers to detect whether you had Alzheimer's was actually to check how atrophied your hippocampus was. Simple as this. This is only 15 years ago, and this is what we had to do. So what you can see here, here's a normal hippocampus cut through here. That's your hippocampus, and we'll talk about that a lot later in the course when we talk about memory mechanisms. And you can see in an Alzheimer patient how it's atrophied. So this was how people were initially deciding whether or not someone had Alzheimer's disease. But this is fraught with difficulty because there's other things that can cause atrophy. And the world needed a much better and more specific marker of whether the patient had Alzheimer's disease. Because experienced clinicians, absent other imaging information that I'll show you, experienced clinicians who've seen lots of patients and probably be wrong in their diagnosis 5 or 10% of the time at autopsy. And that's a big problem, because if you're trying to do a clinical research trial and you're trying to make somebody better, and you're targeting a specific disease and 10% of the target population doesn't have the disease, you've just thrown 10% of noise into your statistics, which may obfuscate or hide a true effect. So what did we end up developing? First, PET glucose scan. Now, we talked about PET in the course. You know what that's about. A positron bounces into an electron, it annihilates, emits 2 photons. The detector picks it up. And this is some of the first work actually done at Berkeley in Bill's lab. And what you can see over here is glucose uptake. This is radioactive glucose. And cells love glucose. So you can see the uptake around the brain. And this is the first findings that in Alzheimer patients, you have hypometabolism in the back of the brain, in the temporal parietal and hippocampal regions of the brain, right? Decreased. There's not as much glucose pickup. Now, that's nice, but it doesn't prove this is Alzheimer's, because you could see that same pattern if I had 2 strokes in the parietal lobe. You'd have no glucose uptake because there's no tissue to uptake the glucose. So can we get a little bit better? And the answer is yes, we can get dramatically better. And this was really a phenomenal addition to the entire field. And this is work done by Chuck Mathis and colleagues at Pittsburgh. But Chuck actually did his initial training with Bill at Berkeley. So there's this line of research coming from here. And they developed basically Pittsburgh compound B. And we don't need to get into the substructures and the rings and the organic chemistry. Basically, it's a tracer that you inject that's radioactive, and it attaches to amyloid, period. Okay? That's all you need to know. So now you say, if you got 2 people, and they're 75 years old, and I give them this PET tracer, theoretically, there should be no uptake in their brain unless they have amyloid deposition, right? And it turns out this group did a tremendous study where they not only looked at PET scans in people early on symptomatically with maybe mild Alzheimer's and followed them to death, got autopsy material, and confirmed that their PET findings 5 or 6 years previously, which showed increased binding to amyloid, PET binding, those patients had amyloid deposits at death. So this was linked. This is the link, and that it became approved at that point for a medical test to see whether you have Alzheimer's disease. Now the problem, of course, we don't have a specific treatment yet. So the insurance companies say, we're not paying for your family member who's a little bit out of it to get a PET scan because there's no treatment. We're not paying $4,000. So that's a problem right now. But I will tell you this. Once we get a more effective treatment, which we will, because there's a lot of people going at this problem, we will figure this out. You're going to see PET scans being done all over the country in older people, or maybe some other new test that will develop, because you'd like to know, someone at my age, I'd like to know, do I have any amyloid plaques being deposited? I'm presumably still normal. I'll let you guys decide if that's true or not. But and if I did have plaque deposition, I'd want to be treated. It's a little bit like if you find out your glucose is running high at 140, you'd want intervention, or your blood. So the same logic will apply to this as the field develops. So Pittsburgh compound B, a dramatic and critical advance. Now you look at the brains of people with Alzheimer's with the glucose, fluoride deoxyglucose, and I've already shown you they get this decreased glucose uptake. But these same patients also, the red shows they've got amyloid deposited all over their brain. Okay, this is again work done at Berkeley in this area. People don't quite understand. People think, well, Berkeley's not a medical school, so we don't do this kind of stuff. It's not true. A lot of the basic research in a lot of areas that end up in clinical translational interventions actually originates in campuses like Berkeley, where people are doing predominantly, we're not doing clinical trials, we're doing basic research that will then inform and help fine-tune and develop appropriate clinical trials. So here is 3 Pittsburgh compound B amyloid PET scans, Alzheimer's disease, on the top. Amyloid all over the brain. Normal aging, amyloid negative. Normal aging, amyloid positive, non-symptomatic. 14% of people over the age of 70 have amyloid in their brain and they're not symptomatic. That's the group you want to intervene with, because as the disease gets to the state of that unfortunate lady that Dr. Jagus examined, it's too far along to really reverse the pathology. You got to get in early to stop the effects. So this is a really nice example of that. Now, it's become increasingly clear that not only amyloid is important, but tau protein is. And what's happened is there's been a big increase in developing tau PET scanners. And I'm not going to go into the details of this, but there are many subtypes of frontal temporal dementia. We're going to not go into these, the specific subtypes, but all of them are associated with deposition of tau protein. Just like in pure Alzheimer's, you predominantly get associated with deposition of amyloid, although there's some tau too. But in the frontal temporal dementias, there's almost no amyloid and lots of tau protein. And as we go when we talk about traumatic head injury later in the course, and we talk about chronic traumatic encephalopathy from repetitive head injuries, the pathology in that particular syndrome is actually tau deposition, not amyloid. So this is another important biomarker of disease function and helps us segregate the types of diseases that we're dealing with. And this is just these different variants, all showing various amounts in red of tau deposition in the brain. There should be none, 0. Now, here's the tricky part. This is your cognitive ability, and this is, here, age. At some point, your cognitive ability may slide a little bit with aging. Could almost be considered normal to be not quite as sharp when you're 80 as you were when you were 20 or 25. The question is, when do we say someone's demented? Where do we actually say grandma's really not functioning properly? And that's a clinical call. Right? There's no simple marker that will tell you that. At some point, we say the person has mild cognitive impairment, and this is millions of people in this country and worldwide. Millions of people have mild cognitive impairment. The question is, are these people going to progress into dementia? And when they have mild cognitive impairment, what's the cause? Is it because they're laying down amyloid, like I showed you in the, quote, normal person, right, who still had deposition of amyloid on his PET scan? So these are really important questions that people are dealing with as we speak. But what you want to do, of course, you don't want to be treating somebody down here. The cat's out of the bag, the cow's left the barn, whatever you want to say, the disease has really progressed and it's really hard to remove. Actually, right now, it's impossible to reverse it. You want to be able to intervene at a much earlier time to treat. And that's the magic, is to not let the person get cognitively impaired and certainly not let them slide into dementia. And I'll just say, for those of you really interested in this topic, Dr. Jagus teaches a full course just on aging and dementia in the School of Public Health, which I haven't taken, but I'm sure it's good. Bill's funny. He's entertaining. So what are the treatments that we have now that have been tried? And there have been many treatments tried for Alzheimer's disease. Remember I said that this area deep in the brain degenerates and you lose acetylcholine to the cortex? People have tried acetylcholine replacement, cholinergic replacement. It has a modest effect. It helps an Alzheimer's patient for about maybe 6 months, maybe 20% of the patients. They don't get necessarily better. Their rate of decline becomes less steep. So this is not a powerful treatment. It's really palliative. It's not at all like giving dopamine to a Parkinson patient, where you get fabulous results in 85% of the people. It's mildly effective. And then there is a raft of anti-amyloid agents that have been tried. And you could just, go on your computers and you'll find untold numbers of these, most of which have failed. Actually, all of which have failed. So anticholinesterase medication, ASE, we never see ASE on something, it means it's breaking things down. So cholinesterase breaks down acetylcholine. So you give medications that block the cholinesterase, to try to bump up the cholinergic activity in this deep brain structure, the basal nucleus minor, that projects all over the cortex, bathing your cortex and your hippocampus in acetylcholine. And if you just selectively stopped the acetylcholine to the hippocampus, let's say in a rat model, you get profound memory problems. So you need acetylcholine. You need it to set the tone for your memory structures to work. But as I said, these are mildly efficacious and only for a short period of time. So what about amyloid? We're going to target amyloid, even though I'm telling you now, because you're educated consumers, it is not clear if this is really the right. A lot of the trials targeting amyloid have failed. So there's been some rethinking in the field as to what actually should be done in terms of trying to treat it. But just let's do this. Amyloid precursor protein is a normal protein. This is your cell membrane. This is the outside world. This is the inside of the cell. The cell membrane, and there's this amyloid precursor protein, and it's clipped. And there's things that ASE, clip, beta and alpha secretase, and it clips it into pieces, and then it gets recycled and reused in the cell membrane, and so on. What happens in Alzheimer's disease is you get another clipping where the length of the precursor protein is cut much smaller, which makes it more soluble. So it floats around in the interstitial fluid of your brain, and eventually, just like a crystal, if you have too much of a salt in a solution, it'll crystallize. These things start aggregating and crystallizing in your brain. So you can imagine now, there's different things. Maybe we could target this beta secretase. Oops, where am I going here? Maybe we could target this. You can imagine all the potential targets for treatment. So the brain plaques, because we're getting little pieces of this A-beta peptide, they tend to aggregate into a layer, like a layer in a cake, and precipitate as a little crystal. This is the amyloid plaque in the brain. It's composed of deposition of these little inappropriately cut snippets of protein in your cell membrane. Again, you have the precursor protein here, and if you cut it too small, it can precipitate into an amyloid plaque. So one simple logic was, one of the first studies, maybe we can decrease secretase and we won't clip so many small pieces and we won't have so much precipitation, and we'll decrease the plaque load, and then we'll decrease Alzheimer's. Okay, so here's a little schematic. Here's your amyloid plaque in the brain. If you don't control it, your brain eventually atrophies, and you lose all your cognitive ability. So you have these different steps, and you don't need to remember all these steps. I'm giving you this so you know the logic of the field in trying to control this disease. So you could basically try to block the inflammation that's associated with an amyloid plaque. So there's a lot of trials about using basically ibuprofen. Big trials. Can we stop inflammation? Didn't work. Can we do secretase inhibitors in different parts of these clipping proteins to decrease these, ending up with these little soluble pieces of amyloid that can precipitate into the amyloid plaque? Didn't work. Anti-aggregation, can we target them actually after they've been inappropriately clipped? Can we do something to stop them from crystallizing? So far, didn't work. And again, anti-inflammatories didn't work. But a lot of people trying a lot of things. What else has been tried? Well, what has been tried is immunization, right? You've all been immunized, right, for something. So what the idea was this immunization is you can make a genetic strain, a rodent strain, that has Alzheimer's. So you've got a model that has, I shouldn't say it has Alzheimer's, it deposits amyloid plaque, and it gets progressive cognitive problems. The rat can't do maze learning and all those kind of rat-type things that are testable, the Morse water maze, etc. So the idea was, okay, how about we immunize the baby rodents who are going to develop amyloid deposition, and maybe we'll immunize them with amyloid, and maybe your body's immune system will clear out the amyloid. It turns out it works in rodents. So this led to a huge clinical trial in Europe in patients with Alzheimer's. So this transgenic mice deposits amyloid in the brain. You vaccinate the animal at birth, and you get decreased amyloid, and you get a smarter mouse. Okay, pretty cool. Can we take that and do it to humans? Big trial. It worked in the sense that the people got an immune response, but they really got encephalopathic. They got such an immune response, their cognitive capacity even deteriorated. And the reason it may have happened is that the clinical trial targeted people who already had a heavy amyloid deposition. They were already into the moderate phase of the disease. So, yeah, you kicked in the immune response, and they got this massive inflammatory response. So the logic now is we don't want to abandon this. The logic may be to take somebody who's got a PET scan, who's normal, but has some amyloid deposition, and immunize them. We'll see how that plays out. That trial is being planned, and it would be great if it worked. So I'm just kind of showing, secretase inhibitors, drug clearance, immunization. People are trying many, many approaches. Now, what we do know is that Alzheimer's is not really a genetic disease in most people. Yes, there's a slight increase. If you have a loved one who had Alzheimer's, you probably have doubled your chances of getting Alzheimer's from 2% to 4%. But it's not a massive, you're not assured of getting it. But there are certain genetic disorders that present with an Alzheimer-like pattern with amyloid deposition and progressive cognitive decline. And if you look, so there's deficits in amyloid precursor protein. These are early onset cases. And when I mean early onset, this is in the 30s and 40s. There's a tremendous documentary on, I forget what country. There's a family being followed and being studied in South America. I'm not sure the country. I think it might be Colombia and Johns Hopkins, who have this gene. And if you look at the documentary, you've got people in their 30s and 40s looking like they're 85 years old and completely demented and not able to function. There's other genes associated with this. There's things that most people don't know about. Down syndrome kids, unfortunately, if they live past 40, remember Down syndrome has 3 gene 21s, trisomy 21. And if these kids live past 40, sadly, many of them now develop Alzheimer's disease, in addition to the Down syndrome and the problems that they were unfortunately born with. And there are families of people who don't have Down syndrome, but have a genetic mutation on chromosome 21 who also get early onset Alzheimer's. Now, these are the known genetic ones. Most of the cases that you'll see in your life really are late onset, sporadic, with not a very big genetic load on other family members. ApoE4, for those of you in who knows what ApoE4 is? Oops. Okay. This is basically a protein associated with cholesterol metabolism. It turns out if you have this particular abnormality, ApoE4, this increases your risk of late onset Alzheimer's disease. This is a bigger risk of getting it than actually having a family member with Alzheimer's. So we always screen people for the ApoE4. The tau protein mutations on tau are linked to the frontal temporal dementia, but not to Alzheimer's disease. So what I've been talking about is Alzheimer's, and now we're going to switch to frontal temporal dementia. And frontal temporal dementia is probably 5 to 8% of all dementias. We're fortunate in the Bay Area, we have one of the world centers for research in this area at the Memory Disorders Clinic over at UCSF, run by Bruce Miller, who's a friend of mine and has a fabulous program doing research in dementia all the way from animal models all the way on through clinical trials. So he, being in the med school, he has all the basic science that we have, but he also has the ability to do clinical intervention trials because, it's a med school. So, all right. So before we talk about frontal temporal dementia, I want you to take away from here the idea that getting dementia, it's multifactorial, Alzheimer's. They're causal genes that unfortunately, they're causal genes that I just described. If you have them, you're going to get Alzheimer's. There's basically things that ward off Alzheimer's, and that's being mentally active. Doesn't mean you're stopping the deposition of amyloid, but you're increasing non-damaged areas of the brain to have them engaged. So social interaction, physical exercise, thinking, reading, interacting with people. People who do that as opposed to being a couch potato for the same amount of amyloid in their brain, same amount. The person who's got an active social cognitive world is going to do much better than the patient that sits there and just watches TV, unless they only watch on TV the Golden State Warriors, and then they should be completely normal, don't you think? Is that, no? Sorry, that was a really bad joke. Non-steroidals basically don't help. If you have vascular disease and you're already not producing good blood to your brain, that'll increase your chances of getting Alzheimer's. Prior head trauma, where you're knocked out, has a slight increase of your chances of getting Alzheimer's later in life. You have risk genes. So there's lots of things that the clinician is thinking about when they're trying to sort out exactly what's going on in this individual. So now the frontal dementias, basically, because they start in the frontal lobe, the anterior parts of the brain, the areas that are important for executive control, decisions, planning. What are you doing tonight? What did I do yesterday? Can I go back in time? What am I going to do on spring break? And, how am I going to prepare for this exam? All these high-level executive functions, that's what starts going first in these patients. And they often have problems in what's called social comportment. They're not acting appropriately with other people. That could be the first symptom. So profound executive dysfunction, initially good memory, good language, good visual spatial skills, just the opposite of Alzheimer's disease. Just the opposite. The behavioral deficits, early, prominent personality changes. Grandpa is not grandpa anymore. Something's off. And it's not his memory. He's acting odd. And people will often say that the family member is acting cold. They've kind of disconnected from normal human kind of interaction. They just feel that they've become distant and are not connected to their loved ones anymore. Poor judgment, poor insight, often disinhibited. They do things that are inappropriate. They can get them into trouble. They can be labile, socially inappropriate. Sometimes they'll do inappropriate sexual things that they would, that is not part of them. They have this inability to control their social, emotional interactions with other human beings. Frontal release signs on neurological exams, but no sensory or motor deficits. So you remember when we were doing the neurological exam, the frontal release signs, the snout reflex, the grasp reflex, these are the kind of signs that you would see in these frontal temporal dementias. You'd see them in Alzheimer's disease, but not until late in the disease. Remember, Alzheimer's is starting in the back of the brain. It takes it years to sweep forward and involve the front of the brain. Frontal dementias. Age of onset much earlier than Alzheimer's disease. Remember, Alzheimer's, I said, rarely starts before 65, and the peak onset is after 75. These frontal temporal dementias often onset in the 50s and 60s. And a frontal dementia looks like this, okay? So we go over here on the left top. Here's a sagittal. Oh, whoops. Stop. All right, so listen, what we're going to do is we're going to do epilepsy on Monday, then I'll come back and finish dementia. I want you to have the epilepsy to be prepared for the guest visitor on Wednesday. Thank you.